Happy New Year! Welcome pediatricians to the first online CME lecture for the year 2015 entitled Ang Banta sa Bata ng Leukemia. An estimated 175,000 new cases of cancer are diagnosed annually in children less than 15 years of age. Since 1975, incidence rates of pediatric cancer have consistently climbed the statistical charts. Many of these cancers are curable if diagnosed and treated early. Join me in the next 20 or 30 minutes to learn how we could face the challenge of the rising threat of childhood leukemia. My lecture will cover an introduction to leukemia, the epidemiology and etiology of pediatric cancers, recognition of leukemia through symptom complexes. We will likewise briefly review the algorithm for FUO, and will touch on the classification of leukemias as well as an overview of diagnostic and treatment strategies, and finally discuss the consequences of leukemia treatment and its future directions. Leukemia originates from the Greek word leukos, meaning white cells, and emia, meaning blood. It is a cancer of the blood or bone marrow characterized by abnormal proliferation of blasts or immature cancer cells. These abnormal cells replace marrow elements and eventually interfere with normal cellular functions, leading to anemia, recurrent infections, and bleeding. Based on the SEER 2014 data, pediatric cancer still significantly contributes to morbidity and mortality rates in children from birth to 15 years of age. Leukemia's symptomatology, as we know, is nonspecific and often mimics other disease entities. Although at times difficult to detect, the outcome in children is far better than in adults, especially when diagnosed early and treated adequately. Leukemias are the most common malignant neoplasms among the pediatric cancers by 30%, with ALL accounting for over 80% of acute leukemias in children. The peak incidence is between 2 to 4 years of age, with a sharp decline in incidence during adolescence. The light blue line represents the second most common pediatric cancer, the CNS tumors, with a stable representation across ages, while the light green line, as seen in the slide, represents the third in rank, the lymphomas that peak in incidence during adolescence. The etiology of leukemia is still largely unknown, but is believed to be an interplay of the following factors: genetic, environmental, and infectious causes. Some children possess genetic predispositions to leukemia, or what is known as pre-leukemic syndromes. One such syndrome is trisomy 21 or Down syndrome, which has a tenfold increased risk of developing acute leukemia. Exposures to chemicals such as benzene, formaldehyde, or even passive smoke could put one at risk for cancer. Harboring certain viruses such as HTLV, HIV, or EBV have been shown to hasten leukemogenesis. This means promoting the activation of oncogenes by proto-oncogenes or inactivation of tumor suppressor mechanisms, with the likely outcome being cancer. Cancers therefore develop as a result of a complicated interaction between our genes and the environment and chance. The challenge for us would be to heed the early warning signs of childhood cancer or leukemia. The mnemonic to use would be child cancer, where C stands for continued weight loss, which is always a worry, H for headaches that always needs to be investigated in a child, I for increased pain or swelling, especially if non-responsive to mild analgesia, L for lump or mass, D for development of bruising or bleeding, C for constant or recurrent infections, A for white pupil, N for nausea and vomiting, especially in combination with headaches, is ominous, C for constant fatigue with anemia, E for eye or visual changes, and R for recurrent fever, which will be the emphasis on the next few slides. Another tool to aid in the early detection is to know the symptom complexes observed in childhood leukemia, such as pallor and petechiae that signifies marrow involvement, enlarging lymphadenopathy that points to extramedullary affectation, progressive bone and joint pain, headache and vomiting, unexplained masses, changes in the eye, or even recognizing some oncologic emergencies like hyperleukocytosis, tumor lysis, or superior vena cava syndrome. But the emphasis of this portion of the lecture would be fever as its initial manifestation. Persistent fever of unknown origin, or FUO, is defined to be fever of at least 38 degrees over a week in duration without a known focus. This should bring the following differentials in mind. The most common culprit would be infections, but in some cases may be drug-induced or even be an autoimmune or connective tissue disorder. A pressing matter would be to rule in or to rule out the dreaded cancer. The algorithm of FUO begins with a complete history and physical exam to determine the line of investigation. Positive findings will direct specific tests. If findings are negative, basic tests like the CBC, ESR, CRP, urinalysis, cultures, PPD test, chest X-ray may be of help. Positive findings from such tests would prompt more definitive procedures. If still not conclusive, more tests in the form of scans could be warranted. At this point, you are likely to be able to choose among the likely cause of fever, whether infectious, autoimmune, or malignant in nature. If infectious or autoimmune in etiology, these tests may be added to the panel to guide appropriate management. But if cancer is the suspect, a hematologic evaluation, inclusive of a bone marrow evaluation with flow cytometry and cytogenetics, becomes vital prior to commencing treatment with chemotherapy. In a review of 185 pediatric patients with FUO, 6.4% were of malignant origin. In another study of 113 children presenting with fever for over 3 weeks, 9.7% were due to a neoplastic cause. In a local study in PCMC, among 59 pediatric patients with prolonged fever, a high 17% was due to cancer. Some studies have proposed the naproxen test as a reliable means to differentiate malignant from infectious fever. A positive naproxen test entails lysis of fever within 24 hours of the test and signifies malignant fever. A Cochrane review by Oxford Evidence-Based Medicine, however, concluded that the use of procalcitonin bears a higher level of evidence in differentiating infectious fever from tumor fever. The clinical onset of symptoms in leukemia are quite rapid, but also nonspecific. The signs and symptoms may reflect infiltration of the marrow and extramedullary sites. More than half will present with prolonged fever with no or transient response to antimicrobials. Headaches and vomiting could indicate CNS involvement in leukemia. In a study conducted in St. Jude's on 432 children diagnosed to have acute leukemia, it is interesting to note that 70% had enlarged lymphadenopathy, 66% had hepatomegaly, splenomegaly, or both. 57% presented with prolonged fever. The diagnosis of leukemia is rather straightforward. Listed here are the tests usually requested to arrive at the definite diagnosis. CBC proves the presence of cytopenias. Peripheral smear is routinely reviewed as this may already show the pesky blasts. Bleeding tests and metabolic screen, kidney and liver function tests, and urinalysis are routinely part of the workup. Chest X-ray is requested to document mediastinal involvement. Abdominal ultrasound to check visceral involvement. 2D echo is requested more as a baseline test prior to commencing treatment. BMA is performed either on the anterior or posterior superior iliac spine, preferably under sedation, because the initial bone marrow procedure is likely to be difficult because the marrow is packed with leukemic blasts. The aspirates are then sent for morphologic evaluation, then subjected to flow cytometry or immunophenotyping and cytogenetics to create a specific clinical profile. Lumbar tap is routinely done to determine CSF affectation by leukemic blasts that translates to poor risk and prognosis. Acute leukemia was mentioned is diagnosed through bone marrow aspirates, showing more than 20% blast replacement on morphologic evaluation. Subsequently, it may be sent for cytochemical testing to determine if TDT positive, as in acute lymphoblastic leukemia, or MPO positive, as in AML. The marrow aspirates then undergo flow cytometry to determine specific cellular characteristics through clusters of differentiation that leukemic cell clones express. Cytogenetic evaluation is the next important step, done through PCR or FISH. The results are then compiled to create a specific profile, which, much like a fingerprint, would dictate subsequent risk and treatment planning. Leukemias could be classified in two ways, depending on how quickly the symptoms develop, from days in acute leukemia to months or years in chronic leukemia. They may also be classified by the type of leukemic clone that predominates. If myeloid, it could be labeled as acute myelogenous leukemia or chronic myelogenous leukemia, or if lymphoid, as acute lymphoblastic leukemia. The chronic lymphoid leukemias only exist in the adult group and is never seen in the pediatric population. The French-American-British classification was created to integrate morphologic features of these lymphoid blasts into L1, 2, or 3 variants depending on certain morphologic differences. The most common in ALL will be the L1 variant. The WHO revised this classification to include common cytogenetic aberrations linked to morphologic variants. We see that 75% of most ALL cases are of the precursor B type that carry these cytogenetic abnormalities. They have found this information to have prognostic significance. Let's take, for instance, translocation 1221 or TEL-AML fusion, wherein the presence of this gene in an ALL patient actually confers good risk, whereas the presence of translocation 922 or the Philadelphia chromosome, as you see in this slide, portends very poor and dismal prognosis. In a way, the diagnostic and therapeutic process in acute leukemia is like risk profiling. Hypothetically, a patient that carries hyperdiploid D or more than 50 chromosomes could be predicted to have good response to conventional treatment with an excellent prognosis, as you see here, in 85 to 95% 5-year event-free survival. Whereas a child with an MLL translocation, seen in this blue box, is not expected to do very well with only 30 to 40% 5-year event-free survival and will likely require a stem cell transplant after first clinical remission. Our risk-adaptive chemotherapeutic approach is broken into several phases of treatment, as shown in this slide. Each phase of treatment with a specific goal to eradicate more than 99% of the initial leukemic burden in 4 to 5 weeks from the onset of treatment, while the rest of the phases are administered to keep the patient in a leukemia-free state or condition of remission. Another strategy used in the treatment of leukemia is the use of various anti-neoplastic agents in combination to target the different phases of cell cycle, leading to an effective tumor kill. Much of the success in the treatment of leukemia in children is brought about by implementing risk stratification and combination chemotherapeutic strategies. The treatment for high-risk ALL groups is even more complicated, with a need to involve other treatment modalities such as radiotherapy, use of targeted therapies or immunotherapy in combination with conventional chemotherapy. Some would still end up requiring a bone marrow transplant despite repeated treatments. Let's take a concrete example of a child with favorable clinical traits. This child will likely be female, as is seen in the green box, between the ages 2 to 10 years of age, with no evidence of extramedullary nor CNS involvement on initial presentation, with a WBC count of less than 10. Upon BMA morphology reveals L1 variant with good cytogenetic risk and ideal response to initial steroid treatment. This particular patient will be classified under low risk, as you see in the graph to the right, labeled low risk or standard risk, wherein this patient is expected to attain cure after 2 to 3 years of chemotherapy with a 4-year event-free survival of 80 to 90%. In contrast, another child bearing all the unfavorable characteristics listed in the orange box will fall under the high or very high risk as indicated on the graph in yellow or orange, would be predicted not to do so well with the rest of a chemotherapy treatment and probably achieve transient remission only and relapse later on, and is likely to have a 4-year event-free survival of only 33%. These will be the patients who will require more intense chemotherapy at the onset. Treatment for leukemia is not without early complications. While chemotherapy kills cancer cells, it also damages actively dividing normal cells. Early effects include hair loss, mucositis, neutropenia, blood transfusions, a declining nutrition because of recurrent nausea and vomiting. Complications of chemotherapy extend even to years post-treatment. The long-term effects include secondary tumors, secondary leukemias, cardiac dysfunction, endocrine and bone abnormalities, and even cognitive and psychosocial adjustment problems. Many patients are still willing to endure this for the chance for cure and a second chance at life. This could only be made possible through the implementation of the risk-adaptive strategy, combination chemotherapy, and multimodal treatment approach, through a team of experts dedicated to manage every possible obstacle encountered by a child during treatment. It is achieved through good supportive management, by emphasizing good nutrition and infection control. A holistic approach to healing will make the treatment process not only bearable but also effective. All this is coupled with good follow-up care and a watchful surveillance of late effects of treatment. This is the recipe for cure in leukemia. So much has improved in leukemia care, and yet the future for leukemia diagnosis and treatment appears optimistic, especially for the poor risk groups of acute leukemia. New formulations of drugs are being engineered, molecularly targeted treatments are being designed to meet the needs of specific patient requirements. The future may have in store vaccines for cancer designed to use immunomodulation to temper and overcome cancer. Patients with the most dismal outcome in the future could hope for cure too. Such is the case of the design of imatinib, dasatinib, and nilotinib for Philadelphia-positive ALL patients. Improvements in the detection of minimal residual disease, as its name implies, is a detection of residual leukemic cells at certain time points of leukemia treatment that have been linked with the risk for relapse. In the future, they may be designed to pick up the smallest molecular increments of residual disease to help guide treatment decisions and ensure better outcomes. We spoke earlier about clinical profiles that in the future could be replaced by just a single tool through the development of microarray technology. Since certain subtypes of ALL are linked with specific gene expression profiles, they carry the power to predict risk and outcome. They could serve as cytogenetic imprints to guide treatment and ultimately replace many diagnostics to aid in risk stratification, determine drug sensitivities and resistance patterns. Through these advances, leukemia profiling will proceed quickly and efficiently. In summary, pediatric cancer still poses significant risk of mortality in ages below 15 years old. A high index to suspect cancer in children could be guided by the presence of symptom complexes in the mnemonic child cancer. Pediatric leukemia may present with fever of unknown origin in 2.5 to 17% of cases. The use of algorithm for FUO in children emphasizes the basic steps to arrive at the logical list of differentials. Leukemia predominates pediatric cancers by 30%. The final diagnosis of leukemia is made through bone marrow aspirates with flow cytometry and cytogenetic tests to come up with a specific patient profile. Risk stratification, combination chemotherapy, and the multimodal approach are cornerstones in leukemia treatment in children. Advances in diagnostic and therapeutic technology ensures an overall survival of over 80% for good-risk ALL patients and hopefully even for high-risk ALL patients in the near future. The threat of leukemia in children is clear and imminent. It is up to us to stand up to the challenge to preserve faith, strength, and hope. By detecting leukemia early, we aim for a cure. Thank you very much. Please answer the question on the questionnaire page of this site, all for the Filipino child.